Thank you so much for joining our Cancer Support Community, our Cancer Policy Institute's annual forum on utilization management today. I'm Debbie Ware, the Chief Executive Officer for Cancer Support Community. I joined CSC this past March. I'm a master's level social worker and started my career in oncology, working in hospice and palliative care for the first 12 years of my career. I'm so excited to join Cancer Support Community and letting you know that our vision really is we want to serve more patients and meet them where they are. And everything that we're going to talk about today on utilization management are really defined challenges and needs of patients and families. And thank you all for coming together to learn more and ways that we can engage and take action. Our summit today is being recorded and will be available for viewing afterwards. An email will be shared with you in the coming days with all of our registered attendees. If you have any technical or administrative difficulties, please let us know by using the chat box at the bottom of the screen, and we will do our best to address them. In the meantime, I want to thank Dawn Eli on our team and Leah McPherson, who will be helping and being in and out of the chat. Please submit any questions that you may have via the Q&A box throughout the presentations, and we will do our best to get them during today's Q&A portions. We have two panels today, a guest speaker, and at the end of those sessions, we are allowing plenty of time for questions as well. This summit is the cornerstone event of Cancer Support Community's Forum on Utilization Management. And through these summits, we hope to foster thoughtful discussions that engage a broad range of healthcare stakeholders and keep the focus on patients, ask tough and nuanced questions about when various utilization management approaches are acceptable and when they have potential to harm patient healthcare outcomes, and identify new ideas and promising practices that optimize care based on evidence-based healthcare. Utilization management, or for short, strategies are common policies which, when implemented appropriately in the healthcare system, can enhance the patient experience and improve quality of care. However, they can also negatively impact patient access to care and contribute to provider burnout. Since 2019, Cancer Support Community has hosted quarterly roundtables on critical utilization management policies. This year, we held virtual roundtables to discuss three topics: high deductible healthcare plans, the health insurance appeals process, and the roles of pharmacy benefit managers and laboratory benefit managers. Over the course of our summit this afternoon, we will hear about these issues and other strategies, what has happened since we began these roundtables in 2019, and what we can expect to focus on in the future. CSC is committed to fostering conversations that inform and engage all the stakeholders in the creation and implementation of utilization management strategies that include the patient perspective, their caregivers and families, and incentivize cost efficiency through improved patient care and outcomes. We are all here today because we believe that we each have a role to play in making high quality healthcare accessible and available. As we put up a slide, before we get started, I definitely want to take a moment to thank our sponsors for helping us facilitate this important dialogue. And as a reminder, this is dialogue throughout the year as we have held virtual quarterly roundtables for discussion. So I want to thank so much Amgen, Bristol Myers Squibb, Genentech, GSK, Janssen, Merck, Novartis, Pfizer, and Sanofi. Thank you so much for your support. Without it, we would be unable to have these discussions and bringing people together really focused on patient care, patient experience. At this time, I'm so excited to introduce to you the new Senior Vice President at Cancer Support Community for our Cancer Policy Institute, Courtney Yo Savage. And I want to note that Courtney just started a little under 2 weeks ago. Hi, Courtney. 2 weeks ago, and she's jumping in. So that's what we do at CSC. Courtney is our Senior Vice President of Policy and Advocacy. Courtney comes to CSC after 11 years at the Society of Thoracic Surgeons, most recently as their VP of Government Affairs Relations. There, she built a strong health policy team and networks of coalition partners and healthcare advocates. Courtney has worked very closely with the FDA and CMS on regulatory issues and built a strong grassroots advocacy program for working on legislative advocacy. Please join me in welcoming Courtney. We're so excited to have Courtney and her leadership. As many of us, Courtney's also had loved ones who have experienced cancer and gone through that journey. And I know that's what makes all of us so passionate about what we do each and every day. And thank you again for being with us. And Courtney, welcome to your first Roundtable and more to come.
Thanks so much, Debbie. And thank you all. I'm thrilled to be joining the Cancer Support Community team. And it's my pleasure to be here with you today for the 2022 Utilization Management Summit. I thought that I would take a moment to go over a little bit of what we'll be covering today, and then turn things over to Claire, one of my new colleagues, Claire, to get things started. So panel one today, we'll take a look back at the evolution of high deductible health plans, the use of QALYs in measuring value, and pharmacy benefit managers and advocacy efforts in those areas. Panel two, we'll look ahead to 2023 and opportunities and challenges in building a more patient-centered health system. Our discussion will focus on implementation of the Inflation Reduction Act, and the future of legislation like the Help Ensure Lower Patient Copays Act and the Safe Step Act. We're also excited to be joined by keynote speaker, Dr. Larry Bucshon, who will talk about his leadership in efforts to modernize prior authorization. And now I'm delighted to introduce Claire Saxon, the Cancer Support Community's Vice President of Patient Experience, who will be moderating today's first panel. Claire?
Thank you, Courtney. It's lovely to be here with you today. I would like to introduce our panelists for our first panel, looking back at what we've been trying to cover in our utilization management summits for the last 4 years. Please note that all of audience questions will be answered at the end of the panel when we have a Q&A session. So go ahead and use the Q&A feature right now to go and submit your questions. Our first panelist who will discuss high deductible health plans is Cynthia Cox. She's Vice President at Kaiser Family Foundation and Director for the program on the Affordable Care Act. Cynthia conducts economic and policy research on the Affordable Care Act and its effects on private insurers and enrollees. Her work focuses on enrollment, pricing, and competition in the ACA's exchange markets. Cynthia also monitors the performance of the U.S. health system over time and in relation to other large, high-income countries, looking at trends in healthcare costs, access, and affordability, as well as measures of healthcare quality and outcomes. Prior to joining Kaiser Family Foundation, she held research and advocacy positions at Columbia University Medical Center and the American Cancer Society. Our second panelist, who will discuss pharmacy benefit managers, is Greg Gierer. He's the Vice President of Policy and Research at the Better Medicare Alliance, bringing nearly 25 years of policy and advocacy experience to the role. His post at the Better Medicare Alliance follows leadership roles with some of the nation's leading healthcare associations, including PhRMA, the Pharmaceutical Research and Manufacturers of America, and the Blue Cross and Blue Shield Association. Greg most recently served as Senior Vice President for Policy at America's Health Insurance Plans. He began his career on Capitol Hill as an aide to U.S. Senator Christopher Dodd. Greg also serves on the Cancer Support Community's Cancer Policy Institute Advisory Board. Our final member of this first panel is Sarah Van Gertruden. the executive director of the Partnership to Improve Patient Care, or PIPSI, which is also chaired by former Congressman Tony Callejo, original author of the Americans with Disabilities Act. Sarah joined PIPSI in 2011 and also serves as a partner at the firm Thorn Run Partners. Her work is focused on policies to advance a patient-centered health system, from patient engagement in research to driving outcomes that matter to patients in healthcare payment and delivery. Sarah is a healthcare and welfare policy expert with over 25 years of experience, beginning her career on Capitol Hill, working for a Louisiana senator from 1996 to 2003, then as an attorney at the law firm Patton Boggs, where she practiced in the public policy group handling regulatory and legislative issues related to healthcare, welfare, and appropriations. So Cynthia, can you kick us off with an overview of high deductible health plans?
Hi, thanks for having me. I'm going to share my screen to pull up some slides. One second. All right, so I'm Cynthia Cox, I'm Vice President at KFF, and it's Kaiser Family Foundation, but we are not affiliated with Kaiser Permanente. So just like to get that out of the way first. So I'm gonna go over some trends that we've seen in high deductibles. Some of it will be things that you all probably already know, but then I'll get into some of the weeds a little bit too. So as I'm sure most of you know, deductibles have risen and become more common over time. And that's particularly true for people who have small employer coverage, where their average deductible is now $2,500. Even for large employer plans, which tend to be the best health coverage you can get in the private market, the average deductible is now almost $1,500. And when we talk about high deductible plans, I think the definition of what people think of a high deductible plan is changing now that they're so common now. But even when we look at deductibles that are over $2,000, about half of people who work at small firms have a deductible of $2,000 or more, and a quarter of people who work at large employer companies have a high deductible like that too. Similarly, people in the ACA marketplaces who are buying their own insurance, who have a bronze plan or a plan without any cost sharing assistance, they're also likely to have very high deductibles. And in employer plans, sometimes you might get an HRA or an HSA contribution, but even after netting that out, after accounting for any contributions that are made, you still see that people are in high deductible plans. So even after taking into account those contributions, about 40% or so of people in small firms are in a plan with a deductible that's $2,000 or more, not including any contributions. So when we look at what people are spending out of pocket, we can use claims data from insurers to see, well, in what form are they spending money in terms of their out-of-pocket costs. And you can see that deductibles have really just exploded in the last 10 years or so. It used to be that co-payments were much more common. Not even that long ago, people were more likely to have a copay, which is a set dollar amount. So that might be $10 when you fill a generic prescription, or $20 when you see your doctor. That's a set amount that's predictable and it's spread over time, so it's more affordable. But for co-insurance and deductibles, you're much more exposed to the actual price of the service you're getting. So instead of a set dollar amount, you're spending maybe a percentage, in the case of a co-insurance, on the service you're getting. You may not know how much that service is until after you've already gotten it, and then you have to pay 20% of whatever that cost is. Similarly, for deductibles, if you have a high deductible plan, you might not know how much that doctor's visit is going to be until after the fact, and then you have to pay whatever that is up until the point you reach your deductible. And so there's this kind of aspect of fairness where people just aren't able to predict what their costs are. But on top of that, with deductibles, it's also a matter of timing. And so when you have a deductible, if your plan year starts in January, then you're spending a lot of money out of your pocket if you get sick in January, or if you have a chronic illness where you're just using a lot of healthcare throughout the year. And so this is looking at everybody on average, including people who spend nothing on healthcare because they're very healthy. You can see that it's really the deductible that is concentrated at the beginning of the year on average. But regardless of what time of year you end up, maybe getting a hospitalization or having to go to the emergency room, you can blow right through your deductible in one day, no matter what day of the year that is. And the reality is that a lot of people just don't have that kind of money in their savings account. And so we've looked at the liquid assets that people have in their checking or savings accounts to see that, for a low income person who has employer coverage, so these are people who are employed, but they just don't make a lot of money. They have, an average assets of about $2,000 to their name. And so, as you know, the average deductible is now about a little bit more than that. So if someone is low income, has employer coverage, and is sick, they're going to blow right through their deductible, but they're not going to have the money to pay it. And so, this is another way of looking at it. We know that about half of people with employer coverage don't have enough money in their savings or checking accounts to pay for the typical out-of-pocket maximum. So what happens then is that people go into debt. And we have done some of our own studies on this issue, as well as others. There's different ways to try to quantify medical debt. One of the challenges is that when someone has a big upfront expense that they can't afford, they put it on their credit card, and then it looks like credit card debt. It doesn't look like medical debt. But we've come about this in a few different ways through surveys and other research, and we found that about 4 in 10 adults have some sort of debt, whether they're late to pay a bill, or they've put money on their credit card, or instead of paying their mortgage, they paid off some medical bills. So this is a really widespread problem. It's particularly problematic for people who are uninsured, for parents, for Black and Hispanic people, for women. But really, if you can imagine 4 in 10 people, that's going to be a pretty widespread problem, regardless of demographics. So what happens then when you go into medical debt is that 6 in 10 adults say that they have had to cut back on basic necessities like food, clothing, basic household items. And about half of people have used up all or most of their savings when they've gone into medical debt. And here, this is a kind of complex slide, but the point that I want to make here is that people with chronic health conditions who have, basically, they're going to have persistently high healthcare costs. So they're going to be meeting their deductible every single year. These are people who have HIV, cystic fibrosis, certain cancers. They're going to have what we call persistently high healthcare spending. And here we're looking at people who have spending that's in the top 5% of everybody who uses healthcare or doesn't. These are people who are in the top 5% of what we would call health spenders. And the point I want to make too is that 5% of people who are the sickest people are also the ones who account for 95% of all health spending. So if deductibles are a way to get people to think twice about whether they need care or not, it's this kind of like blunt utilization management tool, the people who are most affected by them are going to blow right through that deductible in a matter of days sometimes, and so not only is it causing a lot of affordability challenges for them, but it also probably isn't really affecting any healthcare decision they're making that they have, because their average health spending is way beyond any amount that the deductible would cover. So, this is, I think it kind of calls into question the utility of deductibles when we think about this from like taking a big step back and thinking, well, the people who are accounting for most healthcare spending would also just go right through that deductible almost immediately with one hospitalization or emergency room trip. So just to wrap up, deductibles have risen and become more common over time, and they're harder to afford than copays. Even if you spent Like, let's say your out-of-pocket costs over the course of the year were $1,000 in copays, that would be spread out over time in predictable installments. Whereas in a deductible, that $1,000 comes all at once, and people just don't have that kind of money in their bank accounts a lot of the time. And so, you know, these deductibles are also just this blunt tool to try to control utilization. But I think we need to take a step back too and think about, well, what is really driving high healthcare costs in the US? And it's not so much that we use more healthcare than people in other countries do, it's that we're paying a lot, like paying high prices for each time we interact with the healthcare system. So what might the future hold? Well, you know, maybe the pandemic is an opportunity to think differently about utilization. We're actually at a point now where we might be trying to get people to go back in and use that care that they missed during the pandemic, especially if it was cancer screenings or other kinds of care that can actually provide a lot of value in the long run. Also, you know, if the main reason that we're spending so much money on healthcare in the US is prices more so than utilization, then what should we be thinking about as alternative approaches rather than just continuing to raise deductibles, which might be challenging for employers when they need to retain qualified, you know, staff and offer generous benefits. Maybe there's other ways to get at healthcare costs that don't even have to do with utilization, that have to do more at addressing the underlying prices that we pay for doctor's visits and hospital stays and prescription drugs. And with that, I will wrap it up.
Thanks, Cynthia. Next, we're going to go to Greg, who's going to give us an overview of pharmacy benefit managers. Greg?
Thanks so much, Claire. Good afternoon, everyone. Very pleased to be here for the Cancer Support Community's Annual Utilization Management Summit. I'm the Vice President of Policy for the Better Medicare Alliance and also serve on the advisory board for the Cancer Policy Institute. So wanted to discuss three things and then looking forward to the discussion here. I'm going to talk a little bit of background on the value of utilization management and prior authorization within the healthcare system overall. Second, wanted to discuss how and prior authorization are applied and implemented in the Medicare Advantage and Part D space. And then finally discuss opportunities for reforming the system and next steps. Just before getting into it, a little background on BMA. So we're the leading research and advocacy organization focused on protecting and strengthening the Medicare Advantage program. So we're a coalition of over 180 ally organizations representing health system and providers, consumer and patient advocacy organizations, aging service organizations, as well as Medicare Advantage plans. We also include over 600,000 beneficiary advocates, Medicare Advantage beneficiary advocates, and we engage in the legislative and regulatory process to really protect and strengthen Medicare Advantage, and then also work with third-party researchers to develop new research and analysis on the value and innovations in Medicare Advantage. So just a little background, utilization management, it's a common and prominent feature of both public and private health insurance programs in the US. It's really aimed at ensuring the patient and the beneficiary receive medically necessary care, as well as used as a cost containment and quality tool. So prior authorization is part of medical management, and it's a tool where a beneficiary's provider works with the health plan to make sure that a certain medical treatment, whether it's a service, a therapy, a prescription medicine, is in the best option for that individual's patient needs. Other kind of standard practices include the use of formularies, step therapy, quantity limits, and generic and therapeutic substitution. The rationale behind of all these sort of tools is really to identify and discourage costly low-value services, which in turn will help reduce healthcare spending with not impairing healthcare quality for patients and beneficiaries. Practices, of course, are subject to regulation and oversight. In the case of Medicare Advantage and Medicare Part D, CMS regulates these activities through the Managed Care and Prescription Drug Manual, through regulations and guidance, including on prescription drug formulary design. Wanted to turn a little bit to the Medicare Advantage experience and provide some context around UM and the use of prior authorizations. Most beneficiaries are enrolled in plans that use prior authorization, at least for some services. So there was a study done by our colleagues at the Kaiser Family Foundation, found about 20% of beneficiaries, or 1 in 5, are enrolled in plans that don't use any prior authorization. So most beneficiaries are in plans that use it for some services. There's additional research, survey research, that shows that less than half of beneficiaries actually report ever encountering prior authorization, while 6% said they've encountered prior authorization often. So that's based on a Morning Consult poll from last year. Among beneficiaries that have encountered prior authorization, so this is a subset, a large majority report it poses no burden on access, about 66%. Of course, there's been scrutiny on prior authorization processes and efforts to streamline that. I think this was addressed or brought to attention by a recent Office of Inspector General report on certain practices. Important to note here that Medicare Advantage plans do approve the vast majority of prior authorization requests, as well as provider payment requests, which is sort of a central finding of the OIG. And then on the other side, when you're thinking about UM and prior authorization, it's a really important tool to reduce wasteful spending and low value care. An article that appeared in JAMA early this summer found that Medicare Advantage has fewer instances of low value care. That means tests, treatments, and procedures that provide little or no clinical value as compared to Medicare fee-for-service. And it actually found that Medicare Advantage reduces use of those no value, potentially wasteful, harmful services by almost 10% as compared to fee-for-service. So given kind of the clinical value of UM and prior authorization, I think policymakers and all stakeholders really are focused on ways to improve and streamline UM and the prior authorization process. In the Medicare Advantage space, this has been really addressed in a comprehensive way by bipartisan legislation. This Improving Seniors Access to Timely Care Act. I know Dr. Bucshon will be addressing the conference later, but this is really important legislation that BMA has been proud to endorse and support. It did pass the House of Representatives earlier this year by unanimously by voice vote, which is certainly an important step forward. And now kind of all eyes are on the Senate and kind of the current lame duck session. But just wanted to highlight a couple of the important reforms that are included in this bipartisan legislation. One is it would require electronic prior authorization, really to minimize paperwork and administrative burdens on providers. Second, it would work to increase transparency and data collection on the use and frequency of prior authorization among MA plans. Third, it would ensure prior authorization adheres to evidence-based practice and clinical guidelines, which is very important. Obviously, the value of these tools are only, promoting high-quality care so long as they adhere to kind of best practices and clinical guidelines, and not as just a cost containment tool. And then finally, it would look to expedite the prior authorization process to kind of create a real-time decisions process for items and services that are already routinely approved. And this kind of builds on the work already underway by many stakeholders, including Medicare Advantage plans, to really, streamline and reform the prior authorization process so it can remain a critical tool, clinical tool to reduce low value care, but at the same time, streamline the process so it's, alleviating provider burden and makes the process simpler. And most importantly, ensure patient access to medically necessary and clinically appropriate care. On the regulatory side, CMS is also focused on this issue. As many of you are aware, CMS released a request for information on ways to improve Medicare Advantage that really touched on a whole range of issues of importance. aligned with the strategic priorities and pillars of CMS and the administration around health equity and affordability and access to care. But they were looking for stakeholder input also on ways to kind of improve prior authorization as well, and information such as how plans are currently using techniques such as prior authorization approaches that Medicare Advantage plans are already in place to exempt certain clinicians or services from prior authorization, steps that CMS can take to ensure that does not adversely impact beneficiary access, as well as kind of data and reporting and kind of aligning the data and process to reduce provider burden. So all important questions. The main takeaway here is that there's both bipartisan interest in Congress, as well as from the administration on really ways to kind of streamline and improve prior authorization in ways that kind of preserve the clinical value of the tool, but make it work in such a way that patients have access to all medically necessary and clinically appropriate care, as well as reducing, burdens on providers that are providing medical care. So with that, I'm going to turn it back to you, Claire, and looking forward to the rest of the panel discussion and the questions for later on. Thank you so much.
Thank you, Greg. Sarah, if you could lead us in a discussion of value and the use of QALYs and how that fits into utilization management.
Yes, so thank you. And hopefully you don't all glaze over, because when I can talk about the quality adjusted life year for hours, but maybe it's not the most exciting topic for some of you, but I do think it's a very important topic just to understand, because so much of what is or is not covered is based on assessments of their value. So that's really what I'm going to be focusing on today. So my name is Sarah Van Gertrude, and I'm the Executive Director of the Partnership to Improve Patient Care. As many of you may know, Tony Coelho is the chair of PIPC, and he is also the author of the ADA as was described, but he's also a patient with epilepsy. And, he often talks about when he created the ADA, why he created it, and the goal of inclusion. And I think underlying a lot of these issues is, a goal of making sure that patients and people with disabilities are included in the research, and then and that the metrics that are used to value healthcare don't devalue their lives. So when PIPC was created back in 2008, 2009, we were actually responding to, as a coalition, the hot debate on Capitol Hill around comparative clinical effectiveness research. There was a hot debate in Congress with folks on the far right not wanting to fund this kind of research for fear that it would drive, cookbook medicine, doctors being told what to do by insurers based on research. There was a perspective on the far left that the research should incorporate cost effectiveness analysis, and that it should drive Medicare coverage decisions and Medicaid coverage decisions broadly. PIPC came at this from a sort of centrist perspective, where there was strong support from our members to say, we want comparative clinical effectiveness research, but we don't want it used against us in terms of limiting our options or restricting our access to care that we need. It's important to remember that comparative effectiveness research done wrong, right? If you look at, treatment A versus treatment B, and you can conclude that treatment A is more cost effective simply because it's more cost effective for the majority of patients versus treatment B. Well, what about all those patients on treatment B for whom treatment B is more effective? And so that was sort of the central part of the debate and before the creation of the Patient-Centered Outcomes Research Institute. So we were really happy when PCORI got created, because within its statute, there were 3 seats on the Board of Governors for patients to help drive their decisions. There's a lot of language in their statute that clarifies that they're supposed to look at subpopulations, right? They're not just looking at what works best for the average patient, but looking at what works best for patients within subpopulations, right? Because we all know with personalized medicine that different treatments have different impacts on people. So that's where we landed with PCORI, and we're really excited about that. Also within the statute, and that we're talking about today, is the quality adjusted life year. There was a ban in that statute on the use of the quality adjusted life year metric in Medicare and in PCORI's work. So that was intended to prevent PCORI from focusing on cost effectiveness and instead to focus on clinical effectiveness, and also to make sure that Medicare wasn't using the information to restrict access to care. So what's a QALY? So a QALY is a metric commonly used to determine the value of a healthcare treatment. To calculate a QALY, you must assign a value to a person's life. Because the value assigned to seniors, the chronically ill, or people with disabilities is lower than that of a young, healthy person, QALYs could lead policymakers and payers to conclude that treatments for seniors, patients with chronic conditions, or people with disabilities are not worth covering. Now, this also translates, per our conversation today, into utilization management strategies. If a particular treatment is not viewed to be as cost effective as another, the trend is to then subject it to utilization management strategies that might make it harder for the patient to get to it. Now, it's important when thinking about what was passed as part of the PCORI statute, it actually wasn't a new concept. So as far back as 1992, the state of Oregon had submitted a waiver application to HHS for its Medicaid waiver, where they intended to rely on the quality adjusted life year to determine their prioritized list of services. So in Oregon, their prioritized list of services basically says, if you're above the line, you get covered. If you're below the line, the service is not covered. And not only is it not covered, you don't get access even based on medical necessity or any other kind of appeals process. It's just not covered. So this list is really important in Oregon. That is how their existing waiver functions. But originally, HHS denied the waiver because it relied on the quality adjusted life year to determine what would be above the line, what would be below the line. Now, that was 2 years after the Americans with Disabilities Act passed. The thinking was, well, we've addressed this issue in Medicaid, and then later we addressed this issue in Medicare through the PCORI statute. Come to find out that Oregon is actually still using the quality adjusted life year, which we'll talk a little bit more about, but you're welcome to follow the issue with us at PIPSI. But we've been very engaged in trying to convince their Health Evidence Review Commission that they should be looking at different metrics that are non-discriminatory. We also are seeing not just in Oregon, but in lots of states are looking at studies that rely on QALYs to make decisions, particularly when it comes to preferred drug lists. So the organization that does a lot of these studies, these QALY-based cost effectiveness studies that tend to devalue treatments for people with disabilities and serious chronic conditions, is the Institute for Clinical and Economic Review, ICER. So ICER primarily relies on this quality adjusted life year metric to determine if a treatment is or is not worth it, and then provides guidance and policy recommendations that insurers and others listen to in terms of what they do or do not cover. So as you can imagine, this is problematic. Our concerns about ICER's methodology are largely based on A, its use of this discriminatory metric, B, how it engages stakeholders. ICER does engage stakeholders, including patients and people with disabilities, but there have been a lot of concerns about the information shared with ICER not being then translated into their base case cost effectiveness analysis. It's kind of lumped into the conceptual considerations sometimes, but doesn't define necessarily the value of a product. The other piece that has been very concerning about ICER's studies is their failure to incorporate outcomes that matter to patients and people with disabilities. As PIPSI, we've been really strong proponents of inclusion and making sure that in the research, outcomes that are studied and measured when we think about the value of a treatment, that those outcomes are the outcomes that people really care about, right? That it's, for some people, it's not just about their biometrics. It's how do I feel? Am I able to get up in the morning and go to work? Am I able to take care of my children? And so it's really important that the outcomes that matter to patients be incorporated into the research and the evidence that's being used. There's also a concern that the assessments that are being done at Kaiser in particular are being done prematurely before products go to market. So the only information that they really have that they would consider to be reliable and rigorous are clinical trial studies that are done in the development process, which, as we all know, are not particularly inclusive. You know, they tend to not include communities of color. They tend to not include people with coexisting conditions, people with disabilities. So the evidence is not necessarily representative of the people who will be using the product. So that's been a challenge as well. And then the other challenge has been the lack of transparency and the ability to sort of replicate those studies and understand how the conclusions were made. So nevertheless, today we see a strong emphasis, on inclusion and value assessment and comparative effectiveness research. And we know that at CMS, health equity is a significant priority. So we were actually really pleased. I know Greg described that Section 1557 rulemaking, the proposed rule that the Office for Civil Rights at HHS had come out with in the last few months to get feedback. And included in there was one paragraph where they said, we want your feedback on the use of discriminatory metrics and value assessment with a strong recognition that those metrics can have a disproportionate impact on access for people with disabilities. And so we obviously provided feedback. A lot of groups did. And so we're going to be following that issue very closely to see where they land. Our hope is that they'll provide some guidance that better defines what evidence can and should be used in these kinds of decisions within HHS programs. So anyway, I think that's an important piece of progress. We were also pleased with looking back at the Inflation Reduction Act. There was also some language included in that that talked about comparative effectiveness and wanting to take into consideration the impact on specific populations, such as individuals with disabilities, the elderly, the terminally ill, children, and other patient populations. I'm quoting the law. And then it also went on to say that the Secretary shall not use evidence from comparative clinical effectiveness research in a manner that treats extending the life of an elderly, disabled, or terminally ill individual as of lower value than extending the life of an individual who is younger, non-disabled, or not terminally ill. So we believe that if you take that language and you combine it with the existing ban on using the quality adjusted life year to make decisions about coverage in Medicare, that should mean that this type of evidence is not going to be used as part of their processes for looking at prices of prescription drugs. But we'll see. That's where, with my lawyer hat on, that's what it seems like. We also are hopeful that in this process, CMS will actually establish some standards for non-discrimination and inclusion in the research and the evidence that they're using to evaluate drugs. There's a lot of entities that have surmised about what standards are or should be for good comparative effectiveness research and value assessment. We probably could use some better guidance on that that is more consensus driven, because at the end of the day, there's a lot of concern that key populations are just not included in the evidence base. And yet we're talking about the value of products when we have no information about how those products may be valued by populations that are not included. So it's a challenge. The National Council on Disability has actually also been very engaged on this issue. They published, they're an independent federal agency that advises Congress, the administration on disability policy. So back in 2019, National Council on Disability published a very long report looking at the quality adjusted life year. They came to the conclusion that it's discriminatory as well. And so now we've also got, this year was introduced a QALY ban in the House, and we're very hopeful that will move next year as a bipartisan bill. But we're still concerned because entities like the VA are partnered with Kaiser to use their studies in the development of their formulary. So hopefully, we can advance a more comprehensive and consensus-driven QALY ban going forward. I hope that's helpful. I know it's a lot. but look forward to answering your questions.
Thanks, Sarah. I really appreciate your comments as well as those of the rest of our panelists. It seems like one of the themes that ran through all of our panelists' discussions were the fact that there are ways to use utilization management techniques to promote high quality care. And when used that way, it can actually save both patients and the system money so that we're not using low value care. With high deductible health plans, there are plenty of people who are of higher income who use those in conjunction with a health savings account to make that be a very comfortable, very usable and helpful way to get high deductible healthcare, to get their healthcare. But yet, when you use that same system with people who don't have high incomes, you can see the numbers that Kaiser Family Foundation had around how households just don't have the money available just to pay the deductible on their plans, and the co-pays and the co-insurance on top of that. And so we see people with who are uninsured, low income, and we see patients with chronic diseases really suffer with medical debt. And we know that that's a huge cause of distress and even gets into having patients ration their prescription drugs in order to keep their costs down. And so what are the ways that each of you see in the next year or so that groups who are interested in promoting high quality care as the primary way of using utilization management and the primary goal of utilization management, rather than just the blunt cost containment, what are the primary ways that you see in the next year or so that we can make a difference to ensure that we're moving in the direction of high quality care and not just cost containment for payers? So yeah, Cynthia, do you want to start?
I can get us started, I suppose. I think, so first of all, I would say, I think there's been this move towards higher and higher deductibles because it's an easy, straightforward way for employers and insurers to try to address healthcare spending and utilization. And the idea is that, by having a deductible, that makes patients think twice about whether they need that care, or it might encourage them to shop around for care that is of higher value or lower cost. But, and I think, as we've shown, there's only so much utility that deductibles have. And I think, one of the things that is probably changing the most is the environment around employers is that, when the economy is at near full employment and people are looking for other jobs a lot, then, that means that employers have to think about their whole package that they're offering, not just the salary, but their benefits too. And so I think we've seen we have seen a couple of years now where deductibles have not been rising very much. And part of that is also maybe the pandemic suppressed healthcare utilization because people were avoiding going to the doctor unless they really had to before they were vaccinated. And so it's, there's these environmental changes that have been happening now, of course, with, all of this can change. And if we get back into a recession and there's not as much competition in the job market for employers in the job market, where it becomes easier to attract qualified employees, then they might start turning back to these kind of blunt tools like raising deductibles again. We've done some focus groups with employers to try to see how they're thinking about other ways of addressing their healthcare costs besides utilization, and I can go into that more. I think there's some promising things that some large employers are doing, but the reality is that even mid-sized employers are not health policy experts. You know, they're running a smoothie shop or something else. You know, they're not in the weeds enough to be making decisions like this. So that's why raising a deductible is an attractive option, because it's not as complex as any of the other things that my fellow panelists have been discussing too.
So, Greg, do you have anything to add in terms of things that we can be working on in the next year or so?
Yeah, definitely. I think there's a number of kind of promising ways forward here. Certainly agree with Cynthia's point about, you know, the rise in deductibles, and that, you know, it's a blunt tool, and, you know, can lower premiums, but on the flip side, you know, can be a barrier to patient care, both necessary care and unnecessary care. In other words, it's not, you know, tailored to the value of the services, but rather just a deductible on, you know, basically all services until you meet the deductible. I think, you know, a lot of forward-thinking employers are looking away from, you know, constantly, you know, the trends of just increasing deductibles and other, you know, quality and cost containment strategies that, you know, help moderate costs, but not at the expense of patient access to care. And so there's been a lot of, you know, discussion in both public and private insurance markets around, you know, value-based insurance design, which is really kind of when you're designing insurance packages, making sure that, you know, cost sharing is designed in a way so it provides incentives for high value care, like care for chronic conditions and prescription drugs for diabetes patients, and, you know, making sure that cost sharing for those critical services to manage your chronic condition are, you know, reduced or eliminated, but at the same time thinking about, you know, higher cost sharing for certain low value services. And I think they're all kind of work together. So there's the patient cost sharing piece, and making sure that, you know, when enrollees you need healthcare services, there's not undue financial barriers to needed care. And then on the side and prior authorization, you know, this should not be as a blunt tool to, you know, for cost containment. That's not what it's designed for. It's really designed to make sure that the patient receives the right care at the right time. Now, in practice, that may not be how it always works. And that's why I think policymakers are looking at a number of, you know, important reforms there to make sure that, you know, any strategy is really aligned with clinical best practices, and that there's, you know, robust patient protections to make sure that, you know, patients get access to the care they need. So that's a couple of things. I think in the Medicare space and Medicare Advantage, you know, it's a little different than the employer market as far as, you know, cost sharing and deductibles. Of course, there's the standard, you know, Part A deductible. You know, in Medicare Advantage, you know, it's really the focus is on the coordinated care model, and, you know, making sure you're treating the care of the whole person, you know, whether that's through availability of supplemental benefits and lower patient cost sharing. And so that's really the value of Medicare Advantage when you think about, you know, patients, especially patients with chronic conditions, and to make sure that that care is coordinated, that they have, you know, a usual source of care, that someone's, you know, coordinating that care, making sure that prescriptions are filled, and patient access to, you know, timely preventive care and primary care is really kind of the whole focus of Medicare Advantage. But yeah, I think there's a number of promising ways to move forward. I think there has been progress, but always, you know, more to do. So looking forward to discussing these suggestions and ideas with my colleagues here.
And Sarah?
Yeah, what's funny, I wrote down right care, right person, right time. Anyway, I mean, that's, you know, I think that's the theme here, right? I mean, for us, that is sort of a central goal, is the blunt instrument sort of way of covering things where it's, you know, again, going back to my point about drug A versus drug B, or treatment A versus treatment B, or, you know, the reality is that we live in a world of precision medicine where what works for one person doesn't necessarily work for another person, but yet we do have the capacity in our research and value assessment to be able to discern what works for who and when. And so from a coverage standpoint, I think the frustration that we feel and that we would love to see change is to see payers thinking more about coverage in that context, right? It's, okay, we've got a population that needs this, so we're not going to subject them to the highest copays or the prior authorizations because we know this is what works for them, right? And we're not there yet, right? So if I could say there's one thing that we really want to see going forward, it's more of the, well, I guess two things, more of the evidence that helps us understand what works for who and when. And then secondly, that payers respond to that by making sure people are getting what they need.
Well, thank you, Sarah. Thank you, Greg. Thank you, Cynthia. We are at the end of our time. We're grateful that you were able to join us today in this conversation and hope to continue it over the next year in future utilization forum roundtables. Thank you for everyone for joining us today. Don't go too far. Next up is Congressman Bucshon, who's going to join us while we take a quick break between the panels. So stay tuned and you'll be glad you did.
Thank you, Claire.
Thank you.
Well, hi, everyone. Welcome back. Pleased to be joined welcome back to Cancer Support Community's Utilization Management Summit. I'm pleased to be joined by Dr. Larry Bucshon, who I've affectionately called my boss for the past number of years, and Emily Mace, who is his legislative director. I'll tell you a little bit about both of them, and I'm going to turn things over to Dr. Bucshon to talk a little bit about prior authorization, and fingers crossed, maybe some good news this year still. Dr. Bucshon has served as Indiana's 8th district in Congress since 2010. He is a senior member of the House Energy and Commerce Committee and Subcommittee on Health, and a leader of the influential GOP Doctors Caucus. A former cardiothoracic surgeon, Dr. Bucshon has firsthand knowledge of all the challenges facing patients, caregivers, and healthcare providers in a broken healthcare system. He frequently reaches across the aisle to build consensus and support of common sense healthcare policy. This Congress, Dr. Bucshon has once again led the way in pushing Congress to address urgent issues impacting Medicare reimbursement, promote the use of real-world evidence in support of healthcare decision-making, and of particular importance to us today, reform prior authorization and Medicare Advantage. And I'd like to just quickly introduce Emily as well. Emily Mace currently serves as legislative director and counsel for Dr. Bucshon and manages his health portfolio in Energy and Commerce Health Subcommittee work. She grew up in the Midwest and moved to Washington, D.C. in 2017. Health policy has been her primary focus in the last 5 years on the Hill. So Dr. Bucshon, I'm happy to turn things over to you. I appreciate your time. I know that you have to run to votes, and Emily, appreciate you being available to join us to answer any questions that may come up after Dr. Bucshon has had to duck off. But thank you so much.
Well, thanks, Courtney. It's great to be with you all. And, thanks so much for inviting me to speak at this year's Cancer Policy Institute Utilization Management Summit, and for giving me this opportunity to discuss some of the pressing issues happening right now in our nation's healthcare system. As was mentioned, I was a cardiothoracic surgeon for 15 years, and my time spent as a doctor has helped inform me through the process as a policymaker. I think medical people are very well suited to be policymakers. We identify a problem, look for solutions, and then try to implement those solutions. And so my main issue is, working on things that impact patients and providers. And I've made it my mission here in Washington, D.C. to champion patient-centered healthcare reforms that empower individuals and their doctors to make healthcare decisions. And because healthcare is so personal and highly variable, patients and providers must have freedom to decide which is the best treatment or approach in a particular situation, and bureaucratic regulations limiting these decisions can be detrimental to a patient's life or well-being. That's why one of my top priorities in Congress right now, and a topic you all asked me to highlight today, is passing H.R. 3173, a bill that would eliminate certain problematic regulations currently impacting the Medicare Advantage program. As many of you know, Medicare Advantage is a health insurance program for seniors that currently enrolls 29 million individuals across America, and enrollment continues to rise, having doubled in the last decade. It's critical that we work to provide meaningful and efficient solutions to the issues impacting the program so we can better help the millions of patients who receive health coverage through Medicare Advantage plans. H.R. 3173, the Improving Seniors' Timely Access to Care Act, is really a widely popular piece of legislation. It moved unopposed through the Ways and Means Committee in July, through the Energy and Commerce Committee in September, and subsequently passed by voice vote out of the House, which means it's non-controversial at that point. This bill is one of the most heavily endorsed pieces of healthcare legislation this year by both members of Congress and outside organizations. It was co-sponsored by 326 of the 435 members of the House, and has received more than 500 letters of support from national and state organizations, agencies, stakeholders, highlighting its importance in helping both patients and providers. Many Medicare Advantage plans require providers to obtain prior authorization for certain medical procedures and tests before they can provide care to their patients. Prior authorization can play a role in utilization management, ensuring people receive appropriate treatments while also helping control the cost of care. It's meant to allow payers, particularly health insurance companies, to manage cost of healthcare benefits by assessing its appropriateness before it is provided using evidence-based criteria or guidelines. I've always had a little bit of trouble with this because as a provider, I think providers should be making those decisions, but that's the practical reality of the world we live in today. However, when misunderstood or misused, prior authorization can delay or restrict needed medical intervention and result in administrative burdens for providers. And as you may know, the misuse is occurring, honestly, surprisingly to me. A government report published in May by the Office of the Inspector General of the Department of Health and Human Services found an appallingly high number of cases in which Medicare Advantage plans improperly denied coverage for patients. It found that 13% of denied prior authorization requests met Medicare's coverage rules and should not have been denied. Furthermore, 1 in 4 physicians report that a prior authorization delay has led to a patient being hospitalized. Excuse me. My bipartisan legislation would help streamline and modernize the prior authorization process within Medicare Advantage plans by removing outdated processes, allowing doctors to spend more time with their patients. Inefficiency within the prior authorization process creates unnecessary paperwork, lag time, and a hassle, honestly, for doctors that can delay life-saving procedures. Specifically, the legislation establishes an electronic prior authorization process so that providers aren't having to do things like fax authorization forms back and forth to insurance companies. It requires the U.S. Department of Health and Human Services to establish a process for real-time decisions for items and services that are routinely approved, and improve the transparency by requiring Medicare Advantage plans to report to the Centers for Medicare and Medicaid Services on the extent of their use of prior authorization and the rate of approvals and denials. And finally, encourage plans to adopt prior authorization programs that adhere to evidence-based medical guidelines in consultation with physicians. As a doctor, it's really unfathomable to me that this legislation is even necessary, yet here we are. This is a top priority for me because I know that even the smallest delay in care can be the difference between life or death for a patient. I also know, having spent time stuck at my desk filling out paperwork, how burdensome the prior authorization process can be for providers, honestly helping to lead to stress and burnout. This is highlighted by the 88% of doctors who describe this burden of prior authorization as high or extremely high. Doctors spend an average of 13 hours a week completing prior authorization paperwork, which can require multiple interactions between the doctor's office and the health insurer. This is a significant amount of time that providers could otherwise be spending with patients. The Improving Seniors Timely Access to Care Act has been a multi-year effort for the individuals working on this legislation, and I look forward to the Senate acting before the end of this year. I also want to thank my co-leads, Representative Suzanne Del Bene, Mike Kelly, Ami Berra, and Senator Roger Marshall for their strong commitments to seeing this to becoming law. If passed, this bill would have a monumental impact, helping patients over paperwork and prioritizing the health and well-being of individuals. It's only through our combined voices that we can continue to improve the Medicare Advantage program so that many people who rely on the care can be treated promptly. Of course, HR 3173 is just one of the ways we can work together to improve our nation's healthcare system. Throughout this event, you all will have many meaningful conversations about how we can continue to improve the system, and I look forward to discussing those ideas in the future. Thank you again for having me, and with that, I am open to questions you might have.
Thanks so much, Dr. Bucshon, for those comments. And I'm going to invite Emily to join us as well, just because I know that you may have to duck off as soon as votes are called. So I will get the conversation started here with a couple of questions, but I'd like to invite all of the folks who have joined us virtually to submit questions via the chat for the Congressman and for Emily. So Dr. Bucshon, you mentioned your work on the Improving Seniors Timely Access to Care Act. And I know that we are at the end of the year, which seems to be when everything happens in DC. So I wondered if you could speak a little bit to what you expect to happen over the next couple of days as Congress winds down. We've heard some positive rumors, we've heard some negative rumors. What is the latest?
Well, and specifically on prior authorization, I spoke to Senator Marshall a couple of days ago, and as you probably know, and some of your viewers probably know, the CBO has attached a score to it of about $15-16 billion, and I disagree with that. I don't, if you force the plans to actually approve what they're supposed to already be proving, I'm not sure why there's a cost to that. And then I had that conversation for about 45 minutes with the director of the CBO. However, that's the practical reality. The good news is the administration has been working on a rule at CMS, which may mitigate some of the things that we're including in our legislation, and interestingly, may decrease the score substantially, and that may help us. But I think there's a good chance still that this can get across the finish line, because there's a lot of things going into the end of the year package, so to speak, a large package of funding for the entire federal government. And, Senator Marshall's doing everything he can to get this included. And there are going to be a bunch of pay-fors, things that will offset costs for all kinds of things, and some of which can be applied to this legislation. If that happens, then the legislation will get across the Senate floor and become law. So I'm cautiously optimistic. I think, right now, as you know, if you've been around the Hill for a while, and many of you all on the viewers have been also experienced with Washington. There's a lot of things that could be in, a lot of things that could be out. And surprisingly, members of Congress probably will find out, not too long before we're asked to support legislation of what's in and what's out. But we're working, again, I just spoke to Senator Marshall a couple of days ago. This is a priority for him. And let me just say this, when we had 326 co-sponsors, bipartisan, Suzanne Delbene and I have been working on this for multiple Congresses. Mike Kelly, Republican, Ami Bera, Democrat, very bipartisan across the political spectrum on the Democrats and Republicans. So that really helps, because when you have that kind of bipartisan support, that means there's a consensus that something needs to take place and needs to be done. And that increases our chances of success.
I mean, that's great news. I think that we all are waiting with our fingers crossed. But I did notice that you mentioned Senator Marshall, and I noticed that he and Senator Hassan, and as well as you also mentioned Representative Kelly, and I know that he and Tom O'Halloran have introduced legislation that would, at a minimum, require that Medicare publish in the MA user manuals, the Medicare Advantage manuals that are sent out to potential beneficiaries, information on utilization management tools like prior authorization. Do you see that as a fallback option, or is that in addition to in this Congress, or I mean, because I think obviously both of those things are important, but I was wondering if the committees had shown any preference for a lesser approach to addressing.
Yeah, I mean, I can't comment on their legislation because I don't know the details, but I can just tell you this, that any level of transparency in the healthcare space is a positive thing. So, if providers can understand exactly what is happening in the process, that's a step in the right direction. I do think that it would be additive. Those are the two are different issues, but we really need to come into the 21st century and streamline these processes to be electronic. And honestly, if you have Facebook that uses all these complicated algorithms, right? You would think that the federal government could have an algorithm which would quickly approve a request for a prior authorization on something that gets approved 99.9% of the time, right?
Yeah.
Or even less than that. And so that could be very quickly, almost immediately approved if they want to continue to require that as part of their plan. So, that, and again, shining a bright light on what's happening with the reporting requirement in our legislation is always a positive thing if the American people, and Congress knows exactly how this process is being utilized. And you know, I think that's one of the things that probably the insurance plans don't like as much. But the reality is that all of these things, the legislation you mentioned and what we're trying to do, just increasing a level of transparency will help us improve the process. But, you know, I mean, I hear from doctors all the time. I just did a roundtable with a bunch of general surgeons, and this issue came up, right? That it absolutely delays care, appropriate care. And then you combine that with the Inspector General report, which I'd encourage everyone to find and read, about the denials that are happening in MA plans that should not be denied based on traditional Medicare coverage requirements. Then you know that something needs to be done to change this.
Thank you for that. You know, I think I think that part of that message is we still have a lot of work to do. Yes. You know, so a Medicare Advantage and prior authorization is just one corner of what we're talking about today in terms of utilization management. And of course, Medicare Advantage only really just begins to scratch the surface of the types of plans that many of the people who have joined us today are working with. And so I think that what we're hoping with the MA plans is that we can lead by example and show other health plans how this can be done more efficiently and more effectively. In terms of other utilization management type strategies, some of the things that we're going to be hearing in the next panel, and some of the things that we've discussed earlier today, things like copay accumulators, step therapy. What do you see as an appetite for taking these types of utilization management tools on in perhaps a new Congress?
Well, quite a bit. I mean, you know, you mentioned step therapy second, but you know, that's a substantial issue for me personally, you know, to try to deal with. I mean, I think I understand the premise and what people are trying to do to make sure that people are on, you know, primarily I'll speak about the medications that people are on, and that they're on, you know, the medicine that works the best for them, that is the most cost efficient. However, that, you know, we don't want to reinvent the wheel. There have been patients who have been on certain medications and have already been through, we tried this, it didn't help, we tried that, it didn't help, and now here's the medication. It happens to be an expensive medication, but this is what benefits this particular patient. And, you know, I think that we don't want to reinvent the wheel and go backwards. And if somebody changes insurance plans, you know, they go back to where, well, okay, well, you got to start back with the one that didn't work and the next one that, you know, so yeah, it's that kind of thing. Anything for me, honestly, that impinges on the ability of the providers to provide care, but also being a realist, knowing that people, you know, the providers should look for the most cost-efficient ways to treat patients. Rely on the judgment of the providers and give them the benefit of the doubt that the medications they have patients on accomplish those goals. They properly treat the patient, but they're the most cost-effective way to do that. Now, the other thing you need to consider in this is sometimes the most cost-effective way isn't the best way to get the most compliance. And that's the other issue that in medicine sometimes people don't get, is that say you take a long-acting medication once a day for your hypertension, and you remember that every time you get up in the morning, you take your pill, and your insurance plan says, well, yeah, but now you need to take this, say it's this generic version of the drug, and you have to take it 3 times a day. Well, the data is out there to show that the compliance to medication compliance drops dramatically the more times per day that you have to take a medicine. So in the long run, trying to get people to understand that, you know, if this person's hypertension isn't properly controlled because they're not as compliant, and anyone that's tried to take medicine 3 times a day knows what I'm talking about. Then in the long run, then you'd have higher incidence of heart disease, higher incidence of kidney disease, stroke, and other issues because their compliance level was lower, even though they now were required by the plan to take this cheaper 3 times a day drug when the once a day drug actually was the best drug for them. So that's that issue. And the other issue you mentioned, Courtney, was what?
Oh, well, I want to come back to one of the points that you just made, but copay accumulators.
Yeah. I mean, I think, if you look at things that inhibits people from, and I don't know if there's specific legislation on this. But the reality is any financial barrier, substantial financial barrier to healthcare will have an impact on people's ability to access the healthcare system.
Right.
And so, we want to, I understand that insurance plans have copays because it does, if they're properly set at an affordable level, even a small amount will result in more proper utilization of the healthcare system. That's one of the problems we see, for example, in the Medicaid program, that when you don't have any financial stake in the Medicaid program, you will find that in many cases, people will, for example, go to the emergency room to have their sutures taken out when they could get a doctor's appointment, right? That's improper utilization utilization of the healthcare system. Right. So, it needs to be properly, copays can't be a barrier for people seeking needed treatment. But on the other hand, we have the experience that if you have no financial stake, in my opinion, or some other thing that helps, that will drive people to more properly utilize the system, then you have problems. So, and that's controversial. Not everybody agrees with that, right? I mean, many people, I think, on Capitol Hill think that people shouldn't have any financial stake because, but even small amounts that are affordable for almost anyone really do help. I mean, and I'm one that spent a lot of time in the healthcare system, and I do see a lot of improper utilization of the system, not only by individuals, but sometimes by providers. And so, we need to make sure that the proper things are in place.
Well, yeah, and I think what you've identified here, both in reference to step therapy and in reference to copays, is really, we are in an era of personalized medicine where yes, you can design treatments to a specific person, but these policies are not one size fits all.
They're not. Absolutely, they're not.
So step therapy may be applied inappropriately. It may be applied appropriately, but it could easily be applied inappropriately and deny an individual access to the care that they need. Similarly, an individual with a large upfront copay at the beginning of the year could be absolutely financially decimated, and that could prevent them from accessing health care for the rest of the year.
That's true.
So we need to find a way to make a dynamic healthcare system that is as specialized as the medicine that we seem to have created to help patients and their loved ones.
Yeah, I would agree with that totally. I mean, I think it's really critically important. And with all the technology available today, and I think technology, by the way, and utilizing technology is going to further this cause of a more personalized way to treat patients, right? But with all the technology today, we should be able to assess all these situations, and understand that whether it's copays that you would maybe have in place that people can't afford so they don't go to the doctor when they're really sick, or if you force people to go back and try medicine that's already failed, when in their record, it would be very easy to determine both of those things, is something we need to do a better job of. I mean, every individual circumstance is different. I saw this in my own patients. You can have the same disease process, but the way people react and the way people recover from surgery, for example, and other things is always different. And so, yeah, I would agree with that. We need to be more personal on how we deal with this, both on the medical and financial side of healthcare. And I think we can do that.
Well, thank you. I know that you are headed to the floor for some votes. I want to give one last opportunity for anybody in our audience to send in a question. Emily was so gracious to join us in case Dr. Bucshon had to go. And I would love, Emily, to hear your thoughts. I don't want to put you on the spot, but if you have any additional thoughts on the end of this session or things that you're looking forward to, particularly in the patient or provider space in the new Congress, or, what you plan to do with the boss on energy and commerce next year, or any or all of the above. I'd love to hear your thoughts as we check the Q&A just one more time to see if anybody out there has any questions. I feel like I'm radio DJ, but Emily, any thoughts?
Well, the main thing I was thinking about as you were asking about prior authorization, step therapy, et cetera, is just the overwhelming amount of bipartisan support. These bills that you mentioned are some of the most popular in Congress, and I think that's largely thanks to patient advocacy groups like this that go around and talk to their individual members and senators and say, these are the real issues that we're facing. And I think those are the most compelling pieces of legislation that we can work on. And then you see that reflected in the numbers of co-sponsors that they get. And so I think, like Dr. Bucshon said, we're in a pretty good place for the end of the year, but know that if for whatever reason these pieces of legislation are not included, members and staff are very eager to get back to it in the spring and to work on bills like this. Because I think that's what makes our job meaningful, is to know that the bills that we're promoting would have real effects on people's everyday lives. So those are the bills that we're looking for. And as everyone knows, it's going to be a razor thin margin in Congress. And so we're looking forward to being in the majority and getting to control some of the energy and commerce topics and the schedule. But we also recognize that it's going to be more important than ever that everything that we do, we look for bipartisan agreement because it's going to be necessary to pass, really anything next year.
Thanks very much, Emily. Appreciate that. Dr. Bucshon, any closing thoughts before we let you go do your other job?
No, I just want to thank you again for allowing me to speak to the group and to give my perspective on, this particular legislation. But I would agree with Emily. I think the things that we've talked about today have broad bipartisan support, and that's where the frustration comes in. As you know, but it's a marathon, not a sprint. And so, if this doesn't happen this year, I'm very optimistic that in the next Congress, I think we will get there, particularly on prior auth, because the administration, as I mentioned, is going to put a rule there and mitigate some of this. Everybody knows that's a problem, and it will be addressed. So, no, thank you again. And my office is always, we have an open door, as you know, and we appreciate your input and whatever advice you can give us about what you think should be something that it'd be a priority for the people you represent.
Thanks so much. It was great to see you both virtually. And I look forward to catching up with you, if not later this month, then in the new year.
Thank you very much.
Thank you so much.
Bye.
And so I think we're going to take another quick break, but I'd ask you all to stay tuned because we have another exciting panel coming up just very shortly. So thank you all for joining us, and hold tight. Well, hi, everyone. Welcome back to the Cancer Support Community's Utilization Management Summit. We're excited to have the next group of panelists joining us today. First, I'd like to introduce Rachel Klein. She's joining us from the AIDS Institute. Rachel is continuing a more than 20-year career working to advance federal policies to increase access to healthcare for low-income people and people with disabilities, now with a focus on people at risk for living and at risk for and living with HIV and viral hepatitis. Rachel helps lead multiple coalitions, including the All Copays Count Coalition, which focuses on addressing out-of-pocket costs for prescription drugs with people with chronic illnesses who have health insurance. After Rachel, we'll hear from Sarah Buchanan, who is the Director of Federal Government Relations and Health Policy at the National Psoriasis Foundation. She also serves as co-chair of the Safe Step Act ad hoc coalition, and she is passionate about helping patients get the care that they need. And finally, Bonnie Duffy is a government relations professional with expertise in Medicare, health reform, health insurance issues, and FDA. Bonnie manages the MapRx Coalition, a coalition of patient, family caregiver, and health professional organizations committed to safeguarding the well-being of patients with chronic diseases and disabilities who rely on Medicare prescription drug coverage. So thank you all for joining us. I'm going to turn things over to Rachel to get us started.
Okay, thank you so much. And I'm going to see if I can go ahead and share my screen here. And hopefully you all are now seeing my slides. So I'm going to talk about the Help Copays Act of 2022, which is some legislation that the All Copays Count Coalition has been working on. The All Copays Count Coalition actually came together in 2017 to deal with and try to figure out, wrap our heads around this issue of copay accumulator adjustment policies that everyone just heard a little bit about in the previous session. And we're going to talk a little bit.
Sorry to interrupt, Rachel, but apparently we're not seeing your slides on the webinar side.
Oh, okay. Let me try.
We can try to do them from the admin side if you're not. Oh, there we go. I
think does that work?
Thank you.
Actually clicking the button that said share screen is a good idea. Okay, so as I was saying, we were trying to wrap our heads around this issue about copay accumulator adjustment policies that you all heard just a little bit about in the last session. And I'm going to talk a little bit more about what are those copay accumulator adjustment policies and what is the impact on patients and what can we do about it. So first, I want to just level set just a little bit. I'm not going to spend too much time on this because I know in the previous panel, we talked a little bit about the changing landscape of health insurance and how costs are continuing to go up for patients. People are paying more and struggling to pay more for their health insurance premiums. And then when they have health insurance, the structure of that insurance has really been changing over the last decade. So we're seeing more and more of those first dollar costs of healthcare shifted to patients, and particularly patients with chronic illness who rely on specialty medications. So more and more health insurance plans have deductibles. Those deductibles have been going up, and you'll remember that, you know, the deductible is basically the first amount of healthcare during the year before your health insurance plan actually kicks in and starts paying costs. So during this time period, people are really responsible for the full cost of whatever healthcare service that they're getting, including prescription drugs. And more plans have these deductibles, and they are getting higher and higher. And there is some real implications for patients in the deductible phase. This is some data I actually just learned about this morning that just came out in earlier this month, that patients are 4 times more likely to walk away from a new prescription when they're in that deductible phase than when they are later on in their insurance coverage, and that prescription has a flat dollar copay amount. And I think that that's really telling about the impact that deductibles are having on patients' ability to afford the care that they need. In addition to deductibles, more and more plans are using coinsurance instead of copayments, especially for higher cost prescription drugs. Now, what is the difference between those? A copayment is what many of us are used to paying when we go to the doctor. It's a flat dollar amount that's sort of your share of the cost of that visit. And it's usually $5 or $10 or $25 or even $50, but it's a flat dollar amount so that you know what the cost is going to be for each particular doctor's visit or lab service that you're getting. For higher cost prescription drugs, specialty medications, more plans are using coinsurance that is a percentage of the list price of the drug that people have to pay after they've met their deductible, in addition to their premiums that they're paying for their health insurance each month. And these can be very, very high. They can be as high as 30 or 40 or even 50% of the list price of a prescription drug. And we also heard about other kinds of utilization management practices that more and more insurers and PBMs are imposing on patients that really do erect barriers to patients getting the care that they need. And they range from limiting formularies to particular drugs. And so the patients who need drugs that are not on the formulary may have to go through an extra process to get an exception or appeal a formulary decision, limiting the pharmacies that people can use. And this is happening especially for specialty medications, where you may have to go to a particular pharmacy or use a particular mail order pharmacy for your specialty medications. And of course, prior authorization and step therapy, which can be barriers to people getting the treatment that they need. And these are all lots of changes that have been going on in the insurance landscape that's making it harder for people, especially those who rely on specialty or high cost brand medications to get the drugs that they need. And we have also already heard that people are really struggling to meet these higher costs. There's lots of data. I think Cynthia presented much of this really important data earlier today, that people just in general cannot afford, they do not have in their bank accounts the amount of money that they need to meet their deductibles even once, or their out-of-pocket limit even once, much less year after year after year, as is the case with people with chronic illness. You know, most people who have health insurance don't meet their deductible. They never have as many costs during the year that will meet the amount that their deductible is or their out-of-pocket limit. But people with chronic illness tend to hit those deductibles and their out-of-pocket limit for the year every single year. And when we're now talking about out-of-pocket limits and deductibles that can be as high as $9,000, people just simply don't have that to meet it in any given year, much less every single year. And that is causing more and more people to experience medical debt. And people with chronic illness tend to be more likely than people who are healthier to experience medical debt. And those amounts can be, fairly minimal, but there are 23 million adults who have significant medical debt, which is anything over $250, but 26% of those owe more than $5,000. And people with lower incomes and poorer health, of course, are more likely to owe this. And it does have very significant consequences for them in their everyday life, including the ability to get healthcare that they need. So what does that mean for patients? Many, many patients who have chronic illness and who are relying on specialty medications are turning to copay assistance that comes from charitable foundations or from manufacturers of the drugs to help pay the amount there, to help pay their out-of-pocket costs, their cost sharing. Copay assistance is not like a coupon, although sometimes it gets misnamed that way, and we sometimes refer to it as a copay coupon that you might get from a drug manufacturer. But it's really not the same as the kind of coupon that you will get in the grocery store or for a lower priced drug. So it's not like you're opening a circular and you're saying, okay, I'm going to get, $3 off of my $5 over-the-counter medication that I take on a regular basis, my allergy medication or something like that. We're actually talking about financial aid that people are getting to help meet their out-of-pocket requirements that are set by their health insurers. So the health insurance company, the PBM, are getting paid what they have said is the patient's share of cost. And that's happening even though, you know, patients are sort of getting this funding through a charitable foundation or from a drug manufacturer. This is just the place that people are going, in addition to GoFundMe, in addition to asking their families for help, in addition to, you know, winning the lottery or to income that they get from their jobs, when people are looking to figure out how they're going to afford the prescription that they need when they learn that they need a high cost prescription and they have these high costs, out-of-pocket costs. This is where they're going to get the money. 97% of copay assistance that we're talking about is for a brand name drug that does not have a generic alternative. So a lot of times we hear a critique of copay assistance that it steers patients toward higher cost drugs when they could be using a generic or a less expensive drug. But most of the drugs we're talking about are very high cost drugs, and they don't have a low cost alternative. And these are prescriptions that people learn that they need after they've had a diagnosis, and often after they have jumped through the various hoops that the insurers and the PBMs have established for patients. So they've already done the step therapy, they've already done the prior authorization, and they're probably choosing from the prescription drug that is listed on their insurer's formulary. And at that point, they're faced with a high cost, out-of-pocket cost, and this is when they learn about the financial assistance that's available from the manufacturer. So it's really just intended to help patients meet those needs so that they can start and stay adherent to the medication that they need, that is often life-saving medication. A few years ago, we started learning about these copay accumulator adjustment policies and also something called a copay maximizer. And what these are just decisions that the health insurers and the PBMs made that they won't count these funds that are being paid towards these out-of-pocket costs toward the patient's deductible or out-of-pocket limit. And so what does that mean for patients? Essentially what it means is that you may exhaust your copay assistance, and it may happen early on in the year. Copay assistance is not designed to pay the entire cost of a prescription for an entire year for an insured patient. There are different programs that are available, often through the manufacturers, otherwise through charitable foundations, that may help a patient who's uninsured get access to free prescription drugs. But copay assistance is usually more limited than that because it's designed to fill the gaps that health insurance has for people who are underinsured effectively for the medication that they need. And so what happens is that in the course of the year, a patient may use their copay assistance, and then when the copay assistance runs out, they go to refill their prescription, and they learn that they owe the entire deductible or some large amount of money. It may be a bill for a few $100s or even a few $1,000s. And you remember, you know, for prescription drugs, those out-of-pocket costs work really differently than they do for other high-cost healthcare. When deductibles were first created in health insurance programs, they were really designed for hospitalization costs and other sort of high costs that someone might face from having a surgery or from having an accident and going to the emergency room. And most of the time, when that happens to somebody and they have a high deductible or high out-of-pocket limit, they're able to negotiate with a hospital to pay those costs over time, or to work out a payment plan that helps them meet those expense requirements after they've received the care. With pharmaceuticals, it doesn't work that way. When you go to a pharmacy to refill a prescription, there's no payment plan. You have to pay the full cost out of pocket at the time that you want the refill of the fill or the refill of the medication, or you're not going to leave with that medication. And so that's really what we find, is that patients may be hit with bills that they can't afford either the first time and they walk away from their prescription, or they engage in other behaviors to try to delay the need for a refill by rationing their medication, or just not using it all. And that will result in worsening health outcomes, right? People's conditions may deteriorate. And sometimes the deterioration of those conditions results in other healthcare costs that patient will have to figure out how to pay for, right? You may end up with hospitalizations. You may end up with more providers visits. You may have your ability to work or otherwise meet your daily needs because you're getting sicker. Those other problems are gonna increase. In the case of HIV, when HIV is successfully treated, people will have what is considered an undetectable viral load. And when you have an undetectable viral load of HIV, you can't transmit HIV. But if you're not able to adhere to your medication regimen, you may have viral mutations, you may develop drug resistance, and your viral load may increase so that you'll get sicker, but you also may be able to pass on HIV. So there are lots of consequences that can arise from not being able to stay adherent to your medication regimen. And so with the copay accumulator, you're sort of back to square one on that. So we have state legislation that's been passed now in 16 states that prohibits this practice. This is some data that the AIDS Institute gathers each year about the prevalence of copay accumulator adjustment policies in marketplace plans. You'll see they're quite prevalent, and I can get you, their URL is here. You'll find on our website the full data. But we now, in 2022, we had 12 states plus Puerto Rico that had enacted legislation prohibiting this practice. In 2023, we have now 16 states that will be prohibiting this practice. But that doesn't solve the problem. States can really only regulate those individual insurance plans. And these policies are really quite rampant in employer plans, and especially large employer plans that states cannot regulate. So we have been able to get the introduction of the Help Insure Lower Patient Copays Act, HR 5801, which was introduced this year by Representative McEachin from Virginia and Davis from Illinois. We don't have a Senate companion for the bill yet, but we're looking for sponsors so that we can get that bill introduced in the Senate as well. This bill takes care of this issue in two different ways. Number one, it says that if you, cost sharing that is provided by patients for their out-of-pocket costs has to be applied to their deductible and their out-of-pocket maximum. It also says that health insurers have to count as a covered service prescription drugs that they're covering. And this is a little bit of a more complicated twist on the issue that we're finding in the employer market, because there's more flexibility in the employer market when it comes to prescription drug coverage. But basically, what we're trying to say is that because prescription drugs are an essential service, if a plan is covering prescription drugs, then it has to count toward their essential benefits package. And that means that cost sharing has to be counted for prescription drugs. We had 62 bipartisan co-sponsors for this legislation in 2021. It will need to be reintroduced next year, and we will need to find some new co-sponsors. Representative Davis, unfortunately, lost his primary, and he will no longer be serving in Congress next year. And very, very sadly, Representative McEachin passed away earlier this week. So we'll be looking for some new co-sponsors next year, but we've had so much interest in this legislation that we're very hopeful that we'll be able to find new sponsors and make sure that this bill moves forward. If you are interested in working on this issue or in learning more about it, you can go to the All Copays Count Coalition's website. Here's the URL for it. It's pretty straightforward. And I am happy to stay around for questions after the panel, and also happy to talk to anyone about this issue anytime. Thank you very much.
Thanks so much, Rachel. Really appreciate that. That's great information. And yeah, I think we're going to want to talk when we get to the Q&A about what next session is going to look like, because it is a brand new Congress and it's a whole brand new wide landscape. So I'd like to turn things over now to Sarah Buchanan, who's going to talk to us about step therapy in the Safe Step Act. Sarah?
Great, thank you. So I'm Sarah Buchanan. I'm with the National Psoriasis Foundation, and I co-chair the Safe Step Act Ad Hoc Coalition with Elisa Vadilich at the Arthritis Foundation. So I just wanted to start with defining the terms. Step therapy is a form of utilization management, which is the theme for this conference. It's also a form of prior authorization, which we had a really good conversation with the Congressman earlier today about. Step therapy is when a health plan requires patients to try and fail on an insurer-preferred medication or more than one before the plan will cover the treatment initially selected by the patient and their provider. So, when medically inappropriate, step therapy can delay that patient's access to care, which can lead to some severe or even irreversible health outcomes. So on the left, we have a patient with psoriatic arthritis and some finger and joint disfiguration there that is sometimes caused by a delay in access to care and can be avoided. And, that's just so heartbreaking when we come across that. In this cancer space, it can also cause, some really scary health outcomes. And we've even heard of patients passing away because they couldn't access their treatment at the right time. And I just love this image from the 50-state network. One thing that brings to mind is for each step, it can take patients about 2 or 3 months to prove failure. So the patient may know within days or a week that treatment isn't working for them. But they're still suffering for 2 or 3 months until, the health plan has decided that patient has actually failed that treatment. So long story short, step therapy, when medically inappropriate, can lead to delays in care, and those delays can cause severe irreversible health outcomes, and that's what we're trying to avoid. The Safe Step Act, the way I just quickly summarize it is that would ensure that employer health plans offer a medically reasonable and expedient exceptions process. But I can also outline it for you. Generally speaking, the bill does 3 things. It ensures that health plans offer a step therapy exceptions process, requires plans to respond to an exception request within 24 to 72 hours. That 24 to 72 hour timeframe is really important for patients because they can see physical decline, within a week or so. So we try to keep the response time as fast as possible so patients can get access to timely care. And then the third component of the bill is that it establishes no-brainer circumstances when an exception should be granted. So the Congressman talked about circumstances when a patient has already tried and failed on a treatment. They shouldn't have to try and fail again. We also have the drowsy pilot circumstance. If a drug would make it impossible for a patient to continue their work, then they shouldn't have to try and fail on that treatment before getting to, another existing treatment where they could both help their disease and, get to remission and keep their job. The Safe Step Act is actually based on legislation that's been successful in the states. So in this map, the light blue states have all passed step therapy reform laws. Each of these states are different, and our bill is based on some of the more robust bills that have been passed in the states. A couple things to note here. One is that as the support amongst states increases for step therapy reform, so as more states pass step therapy reform laws, I've noticed it really helps advance support for the bill on the federal level. So it's just been really exciting to see the uptake of step therapy reform laws on the state level. If you've been involved in state-based advocacy, thank you. And if your state hasn't yet passed a bill, keep it up. I think it is possible to hit all 50 states. I think we've reached a tipping point here, and it really does go far for also helping the federal bill. Another thing to note is that we do need to pass bills on both the state and the federal level. And the reason for that is there are differences in jurisdiction. So the state step therapy reform laws apply to individual and small group marketplace plans for the most part. They also apply to fully insured employer plans. But the big group that these state bills don't apply to are those self-insured employer plans, which is about 30-ish% of the nation. So even in states where you have a robust law, like Texas, for example, a big chunk of that population don't have access to the patient protections because they get their insurance through their employer, or maybe they work for a large employer, and so their employer has a self-insured plan. The Safe Step Act, when applied to ERISA, so a federal law, and ERISA would regulate all employer plans, both fully insured and self-insured. So that's why I created this Venn diagram here. The state laws really don't apply to self-insured plans, so we need to pass the Safe Step Act too, so that everyone with a private marketplace plan can gain access to these protections. So the current status of our bill, the Safe Step Act, its bill number is HR 2163 and S464. It's about to expire at the end of the year and be reintroduced with new bill numbers, so no need to memorize these. But it's made some really great progress. Right now we have 192 House co-sponsors. We'd like to get to 218 to really encourage committees to take action on it. So we're still trying to, I guess, run down the clock and play through as the rest of the year to get as many co-sponsors as possible on our House bill. The Senate bill is sitting really nice. It's got 35 Senate sponsors. Unfortunately, we've had no committee action. And again, I really think it comes down to getting that high level of co-sponsors, the way you've seen in the Improving Seniors Timely Access to Care Act. Looking ahead at next Congress, it does look a little bit interesting. On the Senate side, our bill is referred to the Help Committee, and Senator Cassie is expected to be the ranking member. He's also an original sponsor for the Safe Step, so this could be good news for hopefully getting some committee action in the Senate side on the Safe Step Act. On the House side, we've been really working hard with the Education and Labor Committee, and Virginia Fox, the current ranking member, has expressed support for the bill and interest in doing something next Congress. She's seeking a term limit exception. So she might be chair of the committee, and if she is, again, that might help us get some committee action on the bill and try to see the Safe Step Act move forward in both the House and Senate side. What that means for 2023 strategically is we're really hoping to see the bills reintroduced quickly early in the year so we can get a move on getting everyone back on the bill and trying to get to 218 co-sponsors in the House side and as many as possible on the Senate side, and then kind of dial in on asking for committee action. So that's where we're at with this bill and what we're looking for next year. We'd love to have all hands on deck. Step therapy is a form of utilization management, and it's one that can really lead to some severe delays in care. What advocates can do is, one, again, ask your members of Congress to co-sponsor the Safe Step Act. You can ask them throughout the end of this year, and hopefully we'll have the bills reintroduced next year to make it easy for you to ask again early next year for them to get back on the bill. Some ways that advocates can get involved are lobby days with the cancer support community and get involved in the action alerts, or you can just do individual outreach to your own member of Congress, find out who they are and ask them to co-sponsor the Safe Step Act. The other thing that's really helpful are patient and caregiver and provider stories. So these stories are what make the difference a lot of times for legislators to hop onto the bill. So we heard the congressman talk about his own experience with prior authorization and step therapy. Not every member of Congress has the benefit of being a provider, but when they hear from from constituents in their districts that have experienced it or know somebody that has, or is concerned about making sure that their loved one can get timely access to care, it really makes a difference. And there's all kinds of ways you can share your stories, share it with your legislators, share it with organizations like the Cancer Support Community. You can also share it with media and post on social media. That's also really helpful to put pressure in the local district to make that legislator take action. So that's all I have for you today. I hope this was a good summary of where we are and where we hope to be next year. And I look forward to working with everyone and to the conversation.
Thanks so much, Sarah. That was great. And for our last panelist, I'm going to turn things over to Bonnie Duffy to talk about everybody's favorite topic. This is one of the presentations that I've been looking most forward to. And this is the implementation of the Inflation Reduction Act and all of the changes that just miraculously, or perhaps not so miraculously, happened earlier this year, and what we might expect in the coming years. So Bonnie, I appreciate your insights. Thanks so much for joining.
Thank you, Courtney. And it's really nice to be part of your program today. I'm Bonnie Duffy, and I'm the convener of the MapRx Coalition. And I'm here to talk about specifically Medicare Part D and the Inflation Reduction Act. But I'm really happy to follow my patient advocacy colleagues, Sarah and Rachel, because all of the issues that they talked about and that I'm going to be talking about today really overlap. And a lot of it really leads back to utilization management and ultimately access to necessary prescription drugs. So I wanted to start out just by telling you a little bit about MapRx. MapRx is a coalition of over 60 national organizations. Our organizations represent patient groups, pharmacy providers, senior citizen organizations, and others. And we come around a table to talk about Medicare Part D. Now we have to go back a little bit in history. Medicare Part D was passed into law in 2003. So we're coming up on the 20-year anniversary, unbelievably, of the passage of the law that established a prescription drug benefit in the Medicare program. MapRx came together much like we are today. This law, this Inflation Reduction Act has passed, and now we're all wondering, what is going to happen when this law gets implemented? Well, back in 2003, a lot of patient organizations were really concerned about the decisions that the Department of Health and Human Services, and specifically the Medicare regulator, CMS, was going to make to provide prescription drugs under Medicare. And the MapRx came together really to focus on implementation of the Part D benefit. So through the years, our coalition has grown in numbers and it's expanded our concern. So we watch and engage very carefully with the regulator at CMS, but we also work with policymakers to help make sure that they understand the Part D benefit, the importance and ways that we need to strengthen that benefit. And we also work directly with people like you who are experiencing the benefit and oftentimes have really direct and important experience that can bring to bear on our advocacy that we're doing here in Washington. So I wanted to thank you very much for being here and also tell you that my slide deck is the slide deck itself goes into a fair amount of detail on the regulatory process. After this, your forum today is finished, Courtney and her colleagues will send out my presentation. So I'm not going to go into as much detail as my slide deck is, but I hope that if you have questions now or later that you would reach out to me, and I'm happy to discuss in more detail than we have time for today. So as you know, the Inflation Reduction Act was passed into law and signed by the president just in the middle of August. And so through this law that we've all followed, there are a lot of different provisions in the overall Inflation Reduction Act, but what are important to us here today are the changes to Medicare Part D, which is the prescription drug benefit that is offered to Medicare beneficiaries. This bill, this new law, represents the most major changes to Medicare since it was first put into place, and obviously also the really most significant changes that have been made to the Part D program. There are really three buckets that are areas that we'll be watching closely. There are changes that we would call Part D reforms. There is new authority by the department to negotiate prices, and that there also will be some Part D required inflationary rebates. So those are really the three buckets. A lot of you may have heard that there's not a specific rulemaking that HHS and CMS are required to have around these prescription drug benefit new regulations in the law. And it's a little hard for all of us to get our heads around if we're used to advocating for passing of bills or perhaps getting involved in our state legislatures. The regulatory process can get quite down into the weeds, but I wanted to talk to you today about sub-regulatory guidance. And a lot of times guidance that we see, rulemaking process at HHS, we'll see a large proposed rule with a 60-day period that we can pour through the proposed rule and take a month or two to sit around a table with our colleagues and try to understand what impact these would have on Medicare beneficiaries, and then provide comments to the agency. And then the agency, when they propose and they issue the final rule, have to respond to those. What we expect to see a lot through the implementation of the Inflation Reduction Act provisions are sub-regulatory guidance, which often come in the form of a document that might be called a frequently asked question. It might be put out as a bulletin or other compliance guides. And all of these are ways that the agency will use to explain to stakeholders, which would be the Medicare beneficiaries, the Medicare plans, the drug manufacturers, and people like us, the advocates, what is their intention as they move forward in this. So while this is a little different than what we usually think of, this still is an opportunity to engage with the agency, with CMS and the people who work there, because sometimes there will be a brief comment period. Other times there will be an opportunity for stakeholders to meet with the agency and talk about what their concerns are. One of the things that all of us do as advocates is try to understand who are the decision makers. Right now, for so many of these new provisions around Medicare Part D, new staff and new, a whole new division at CMS is getting up to speed right now. So as we are learning, as we see different people being hired, we're having new faces and different people who we are going to be working with. So that's one of the things at MapRx that we're watching closely of where are entry points and who are the people who we are going to be talking to. Go to my next slide. I wanted to just show this slide very quickly to give you a sense of the timeline. Medicare plans, the plans that offer prescription drug coverage, have to start shaping their benefit early on in the calendar year, as they will make bids in the late spring to participate in the Medicare Part D program. And so we expect early next year that we will see the first round of guidance. And again, some of the issues that we're following at MapRx have to do with a new out-of-pocket cap that will limit out-of-pocket expenses for Part D beneficiaries. And that out-of-pocket cap is also coupled with what we call a smoothing mechanism, which is an opportunity for people, beneficiaries, to spread out their out-of-pocket costs over the course of the year. My guess is that as someone who's involved with the Community Cancer Network, you well understand how oftentimes the first fill of the year might be a very expensive drug. And so when this new smoothing policy is implemented, we will have the opportunity for beneficiaries to, instead of paying, perhaps $1,500 out of pocket in their first fill in January, be able to spread their cost out over the course of the year. The devil's in the details, as you all know. And so one of the things that we will be talking to CMS about is how they intend to implement the smoothing mechanism, and also what are they going to put in place for beneficiary protections. I'm going to skip a couple of the slides on Medicare negotiation, inflationary rebates, because again, they're very technical, and while they will be very important things to offer, I think in our limited time, I'm going to skip to some specifics around what you can do as an advocate to engage. My next slide has some listed as some provisions that were in the Inflation Reduction Act that may not need even sub-regulatory guidance. For example, the new law expanded the low-income subsidy for Part D beneficiaries. And while it's fairly straightforward about how it will be implemented, one of the things that MapRx is looking to have conversations around is we know that not all people who qualify for the low income subsidy have signed up to receive that subsidy. So we're pushing CMS, even though it's not necessarily required by the new law, to try to do some more outreach and some creative thinking about how we can make sure that people who deserve and need that benefit receive it. Another thing that we plan to do is MapRx is stay engaged with Congress. As you know, I don't have to say this given the what you've heard from all of the speakers today, but it's not enough just to pass the law, but the important work as CMS implements these really, really large changes are going to make a real mark on whether the new law has its intended effect. And so one of the things that MapRx will do as a coalition, as an opportunity for over 60 national organizations to join voices, is to stay in touch with key members of Congress on the healthcare committees and in the leadership about how is CMS doing, what are we seeing, what are our concerns, and if we feel like maybe CMS isn't listening to some of our concerns, to also ask Congress to engage. So that is going to be another big opportunity. Another big opportunity really pertains to the work that you all do around utilization management. Medicare Part D, while as a program was a first step in Medicare to move to more of a private sector model. It was the first time for Medicare that the benefit was offered through private health insurance plans. It's a very, very regulated program. And what I personally believe is the reason that access in Medicare Part D works is because of the oversight that happens by CMS. And so one of the things that we will continue as a coalition to be advocating, talking to CMS about, is please continue your oversight of the plans and making sure that we don't see a situation where plans are increasing their utilization management and doing things that, tighten formularies or otherwise restrict access to these very important prescription drugs. I hope through my presentation that you've learned a little bit about ways that you could engage. One of the things that I'd like to invite you to do is email me if the organization that you're a part of is interested in being part of MapRx. We would love to have you around our table. We also do periodic webinars and Hill briefings around the Medicare Part D benefit to help stakeholders and policymakers understand what it is. So with that, I wanted to say thank you very much for the opportunity to be here. And I look forward to your questions, whether they're now or by reaching out to me over email. Thank you very much.
Thanks so much, Bonnie. And as I invite Sarah and Rachel to join us, I'm going to target you for my first question. And I'm glad that you brought up the congressional oversight opportunities. That was actually on my list for Dr. Bucshon, and I knew he was getting the hook. And so I do think that that's going to be a really important piece for all of us to leverage as we continue our advocacy efforts, particularly around IRA implementation. But since I know that we are joined by a number of different types of stakeholder groups, from patients and caregivers to providers to innovators, I wondered if you had any specific benchmarks, any key actions that you're anticipating coming out of CMS. I know that this is sort of an ad hoc process, and we're coming at it a little bit blind, but are there specific benchmarks that you're looking to for the provider community, for the patient community, for the innovator community, things that they will be keeping an eye out for as implementation rolls out?
So I think right now, as I've mentioned, we're watching who's being brought on to do the work, and then we will be looking as we talk to those people at the agency, what's their specific timeline, and when will we see the first sub-regulatory guidance? We would expect, given the tight time frame, we would expect things early in the next year. So they're working really hard. January, February, we would start to see some of that coming out. Another thing that we're watching for is opportunities for stakeholder engagement. And right now, to date, what we've seen is the department is being very selective in terms of bringing in certain innovators, certain national organizations to start that process of listening sessions. We expect to see a lot more of that. And so what advocates can do is either work through their national organizations, they can talk to their members of Congress who they're in touch with, they can talk with any of us on this panel about how can I get invited, or who do I reach out to make sure. Another thing that I think is really important, if you're someone who's not in DC, is establish relationships with your district offices of your members of Congress and your senators. They regularly do town hall meetings. Some of them have healthcare task force, asked to be part of those, attend the town hall meetings and ask questions, raise your hand and tell your own story, which is the most compelling of anything, and ask them, Congress made all these changes to Medicare Part D. What are you doing? What are you doing to follow it? And how can we work together to make sure it's going to work? I also want to mention that, as we look out into the future, we all know in the healthcare system, when you make changes in one area, it's going to impact things in another area. And I know all of us are really excited about a lot of the innovation that's coming down the pike. And one of the things that's, I think, on a continuum, right now we want to look at the rules. We want to look to see how it's going to impact the day-to-day Medicare beneficiary, but we also want to look at how is it going to affect the overall landscape for what prescription drugs are available to patients. And so it's going to take all of us to be talking to each other, to raise our hand at town hall meetings, keep up our relationships as this process goes forward. One of the reasons that we have MapRx, and I believe a lot of our member organizations use us as, you know, we wave the red flag when it's important. And so we, along with our consultants at Exenda, which I'd like to give credit to for my slide deck, is, you know, we're watching, and Exenda is watching these things happen on a day-to-day basis, and we will make sure that people around the MapRx table are aware of those things that are coming. So, Courtney, I think I've given a rather long-winded answer. There's a lot of uncertainty right now.
There certainly is. There certainly is. And I think that that's an indication to our advocates and all of our constituencies to just stay involved, and we will be pushing out updates as quickly as we can. And the other thing, I really liked your point about getting involved at home and attending town hall meetings and becoming a resource for your members of Congress and for their staff. And I would also like to highlight that that's the reason why you have us as advocates, is to help you to prepare for those meetings, to help you to have the most up-to-date information, at the best strategies, to talk through it with you and make sure that you're comfortable going to the town hall meeting and signing up to be a speaker. What am I going to say? How does that work? How is that going to happen? If you want to go into your district office and have a meeting with a staffer, or maybe even the member themselves, we're here to help to support you in those efforts, and we're very eager to help you to make those connections. So those of you who are listening out there, please use your resources. Sarah, I'm going to turn this one to you, and then I'm going to ask everybody else to weigh in. And I see that we have a question in the Q&A, so I'm going to get to that one next. But I hope that we see more from all of you out in Radio Land. But Sarah, the Congressman indicated that there can be some benefits to utilization management. What does it look like when utilization management works well?
Yeah, thanks. That's a good question. And certainly the organizations that support the Safe Step Act aren't necessarily against the use of utilization management. We're just trying to make sure that the system works so that there could be a dialogue between patients, providers, and their health plans. If a utilization management protocol prefers a medication that is going to work for the patient and does save both the patient and the plan money, that can be a positive thing. Where we get concerned is when the utilization management protocols are not appropriate for the patient, or they're inflexible. I mean, we all know, a one-size-fits-all approach to treatment doesn't work. Every patient presents in an individual manner and needs, patient-centered treatment. So what we're really asking for is that dialogue, and for that dialogue to happen in a timely manner and be medically reasonable.
Rachel?
I don't think I could say it any better than that.
Bonnie, anything to add?
Yeah, I think it's well said.
All right, well, our Q&A from the audience goes to the winner is Rachel. Many of the states that you mentioned passed bills responding to copay accumulators, but copay maximizers have recently become more or as common. Do those laws also address the practices of copay maximizers, or will new legislation be needed to address those issues?
So I wish I could give this a very simple answer. It's a more complicated question than it sounds like, but here, let me give it a shot. The language that has been passed in states is not directed at a copay accumulator or a maximizer. So what they basically said, the legislation basically says the same thing that the Health Copays Act says, which is if the plan has gotten a payment for an out-of-pocket cost requirement, it has to be applied to the enrollee's deductible and out-of-pocket max. where it gets a little bit, and so that would apply to a maximizer program as well as to a copay accumulator program. The issue is that most of the time, states have, most of the time, maximizer programs have been implemented more commonly in employer coverage and less commonly in individual coverage and small group coverage. And it's because of this greater flexibility that employer programs have, particularly large employer plans that are governed by ERISA, by the federal government instead of by states. So the limitation of those state laws is that they only apply to the individual and small group markets by and large. So those laws don't apply to those large employer plans, whether it's an accumulator or a maximizer. And that's why we need HR 5801 or whatever it will be renumbered as next year, the Help Copays Act that will be reintroduced next year, because that legislation will address the issue for accumulators, maximizers, and for all health insurance plans.
Well, that's a great transition. Thank you. That's a great transition to my next question. And I will note that as a person who is frequently asked this question, I'm going to be taking notes on all of your answers. So next year we have a new Congress. We have a new legislative session. What is going to happen to all of our advocacy efforts that, I mean, we've talked a little bit about the bills that are going to be expiring at the end of this year that will have to be reintroduced. You know, can you talk a little bit about sort of the cumulative effect of advocacy over a couple of Congresses? And then my favorite part of the question, Congress is going to be even more divided. And so how are we going to get this work done? How, what are our chances? How do we accomplish our goals? So Bonnie, I think I'll start with you on that one.
Okay, I will say look to more activity from the White House and from the agencies. I think that President Biden will want to continue to work towards enacting his agenda, and he will be looking at regulatory tools to do that. However, I will say that on healthcare, it's not an issue that necessarily breaks down between parties. Everybody has a Medicare beneficiary in their family or someone who's tried to get a drug for their child and been subject to, step therapy or other utilization management. So I would say that now more than ever is just the important time for advocates to keep their voices loud and clear and moving forward towards our goals. But I'll turn it to Sarah and see what she has to say.
Yeah, I love that response about, looking to what the administration and the agency is doing. I think any, wide-eyed strategy would look to both, congressional legislative activity and try to engage with the agencies, because agencies within limits can move a lot faster than Congress. Passing a law is hard. I've heard it can take 10 to 15 years on average to pass a law. So it is a cumulative process. And, I'm sure the Part D cap, you could speak to how long the Part D cap took and what those efforts involved. But what I've seen with the Safe Step Act is, it was first introduced in 2017 on the House side. And, slowly the House bill has grown in co-sponsors after every Congress. We saw the same thing when the bill was introduced in the Senate side, slowly grown in co-sponsors. We're seeing that same kind of trajectory with the Help Copays Act. So, process-wise, at the end of a Congress, all the bills have to be reintroduced at the start of the Congress. They are introduced with, at ground zero, basically, and you have to get everyone that was on back on it and keep trying to build up those co-sponsors and keep trying to encourage committees to take action. But that is the legislative process, and I think it is worth sticking to it. And as Bonnie mentioned, keeping up the drumbeat over that long time period. At the end of the day, making sure that patients can access their care in a timely manner is worth the effort. So I would just say, just keep it up, And also loved what Bonnie said earlier about building relationships, in the district level. So making sure you're going to those town halls, asking questions, getting to know your local staff. I mean, that's huge. And that makes it so much easier to get co-sponsors on, as the process moves forward. Rachel, I'll pass it to you.
I love what both of you just said. Those were perfect answers. And the thing that I will just add to that is that I do think that many of the issues that we've been talking about here today do have bipartisan support, right? We know that there's interest on both sides of the aisle to, exercising some parameters around PBMs. And that interest is coming, from Republicans and from Democrats. We've heard interest on step therapy from Republicans, from Democrats. And I think that it's in a divided Congress, if you can identify those issues that cross party lines and garner support on both sides of the aisle, you have that much more chance of moving your issue forward. And agree 100%, it's incremental steps that we take to build the support and show the momentum. Every state that passes the legislation that Sarah was talking about, every state that passes a version of the Help Copays Act adds to the momentum. And HHS is paying attention to that as well, right? Because to many of these issues, there's a regulatory solution that can move us forward, if not address the whole thing. On the Help Copays front, this issue can be solved through regulation, and we've been asking HHS to do that. And it was only after they hadn't done it for a couple of years that we decided to pursue legislation. So we're going to be continuing to look at both avenues to try to get this issue addressed. And you're right also that it does take a long time, and federal legislative campaigns rarely move in a straight line or very quickly. But things can happen that are unexpected. So that's why we can't let up the pressure, as Bonnie was saying, because you never know when an opportunity is going to arise that can create a path forward. So I think we shouldn't, let the changing nature of Congress sort of stop us from continuing to move forward.
Thank you all, and I just want to acknowledge that we just got another comment, and thank you for commenting and submitting to the questions. And I just want to acknowledge a really good point that was just raised, and that a lot of our conversation today has focused around Medicare, and it is also really focused specifically on prescription drugs. And there's a whole universe of other issues out there related to a broad variety of healthcare plans and costs associated with treatment that is not prescription drugs. I think that the reason that we focused on those topics today was because of the legislation that we're specifically working on, or the IRA that just recently passed. But certainly the expectation that prior authorization legislation, as that we discussed with Dr. Bucshon, in the context of Medicare Advantage or Medicare Part C, or however you want to describe it, it was an opening salvo at an attempt to address prior authorization across the healthcare system. And when we're talking about copay accumulators, I think that other copay, the experience of high deductible health plans and copays, we're not just talking about prescription drugs, but it's certainly relevant to prescription drugs. Yes, costs of screenings, costs of follow-up care, all of that is definitely a part of utilization, is a very significant part of the healthcare resources that utilization management tools are designed to impact. And we're monitoring the impact, both positive and negative. So thank you for that comment. That's a really good point. I think that it was our focus today was more situational, but definitely something that I believe all of the advocates on this call are very much aware of. Unless there are any other questions, I might just invite everybody, if you have any closing thoughts as we wrap up this year and look to a brand new session of Congress and a whole new set of challenges. Are there any closing thoughts that you'd like to share with our participants out there in Radio Land?
So the one thing that I wanted to do was inspired by the last comment that came up through the Q&A on the chat, which is you're the best advocate. You're telling your story and your experience is so powerful. And so I'm really glad that you made those comments, and keep on raising your hand, and all of us need to be doing that more.
Hear, hear.
Yeah, I would agree. You know, hearing from constituents like the last person that wrote in a comment influences what I decide to work on behalf of my organization, and, you know, points me in the direction that and my strategic planning. In addition to what we've already talked about, how sharing your story, you know, can influence your legislator to take action as well. So I would leave you with what I left at my last slide is, you know, like Bonnie said, you definitely share your story with all of us legislators, your organization that's trying to represent you, if you're comfortable with the media as well, and you know, get in touch with your legislators and keep asking them to take action and support you on the legislative asks that you know, that your organization is trying to push for you.
Rachel, any closing thoughts?
Again, super well said by both of you, and you know, and all I can do is echo that and say, you know, all of these issues can get really complicated when we're talking about the intricacies of how health insurance works and how prescription drugs get paid for and how that interacts with other kinds of care that people need, and all of the dynamics and changes that are going on in all of those industries, industries that have very powerful lobbyists representing them, and who don't always have the same interests as one another or as patients. And it's really, really important just to remind policymakers at all levels, state, federal, local, that at the end of the day, all of this is about whether or not people who need healthcare are able to get it. And by telling our stories, we just remind them of, you know, where the rubber hits the road and what that ultimate impact of the decisions that they're making is going to have on their constituents, on all of us. So raise your voices and, you know, get involved, and, you know, don't ever hesitate to reach out to any of the advocates who are working on your behalf at national organizations to get more information about how you can weigh in.
Thank you all. This was a really exceptional panel. I'm really happy that this was my first official act as VP of Policy and Advocacy here at CSC. So thank you all. And I'm going to close with a couple of thoughts, but I'll excuse our panelists with our gratitude and my wishes for the happiest of holiday seasons.
Thank you. Bye-bye.
Bye-bye. Well, I'm about to wrap things up. I just want to thank you all for your participation in what was a really insightful and informative conversation today. I hope that you enjoyed the presentations, and I know that we'll look forward to your feedback on this panel and future topics, what we might cover both in the utilization management space and outside. You know, I just want to highlight that, you know, where some of these topics, and I'll walk through a handful of them, are things that we'll be looking to in 2023. But, you know, there are other things that, there are other practices in healthcare that end up being de facto utilization management tools that when applied unfairly and incorrectly, really have negative consequences on the healthcare system. I'm thinking of things like access to preventive screening, physician payment models and quality incentives that aren't aligned with patient and caregiver priorities. Clinical trial designs and post-market RWE that end up defining coverage parameters that in such a way that patients who need those therapies are not able to treat them, are not able to access them. All of those things I think are on the table for things that we will need to continue to be involved in, and we will need to continue to listen and hear from you and how these factors are affecting you in your daily lives. And so as we look to 2023 and look to see some of our favorite legislation reintroduced around copay accumulators and making sure that every copay counts, around prior authorization reform and expansion beyond the Medicare Advantage program, making sure that the patient voice is reflected in comparative effectiveness research and even physician payment models, looking at step therapy and how we can make that make sense so that patients don't have to go back and start at the very beginning just because they're trying to, because circumstances have forced them into a new healthcare plan, or because they were trying to find a better healthcare plan, or because they didn't have a healthcare plan. All of these are it's part of the work ahead. It's part of the challenge ahead, and it's something that I'm very much looking forward to doing with all of you. So thank you once again for your time this afternoon. As a reminder, today's summit was recorded, so if you missed any of today's incredible speakers, you'll be able to view it afterwards. And I do want to just take a moment again to thank our Forum on Utilization Management sponsors, Amgen, Bristol Myers Squibb, Genentech, GSK, Janssen, Merck, Novartis, Pfizer, and Sanofi. And once again, thank you all attendees for joining us. Please reach out to the Cancer Policy Institute at action@cancersupportcommunity.org if you have any questions. That's also a great place to reach out if you want more information on how to get involved in local events with your members of Congress, or any information on advocacy materials that we might have prepared. And please be sure to fill out a short survey at the end of this webinar. We'd love to hear your feedback and ideas for next year. Thank you once again, and I look forward to working with you all.